Hi, everyone. Thank you so much for joining us today in our webinar. Today, we're going to be talking about effective communication in emergency medicine. I'm Samita Heslin. I'm the Division Chief of Quality and Informatics at Stony Brook Medicine.
And I'm Pete McKenna. I'm the medical director over at Stony Brook Emergency Medicine.
And we wanted to start out by just talking about communication in the ED and why it's important. We work very closely with so many members in our team as emergency medicine physicians, and we are directly communicating with each other, with our nursing team, with social work and care management partners, and with our consultants. And it's really integrated into the fabric of emergency medicine. Pete, do you want to talk a little bit about the importance of communication in the ED?
Sure. So the ER is controlled chaos, right? Things are happening from all angles. Patients are constantly coming in, patients are constantly moving out. We're always evaluating, treating, diagnosing new patients, right? And the teams involved are gigantic, right? You're talking CAs, LPNs, RNs, PAs, NPs, physicians, physical therapists, respiratory therapists. I'm sure I'm forgetting a bunch, right? So it's kind of like an orchestra, right? So an orchestra has strings, they have brass, they have drums, right? And they're all kind of going along playing their own sheet music, but everybody has to communicate with one another and listen to what the other is doing, or it just turns into a big jumbled mess. So that's kind of like how I like to describe the emergency department, right? It's all of these different people working individually, but all working towards one final goal, right? And you don't get there without clear, concise communication.
I think that's really a perfect way of describing it. And where do you find that there's these most common communication breakdowns in the ED?
I think probably the biggest breakdown is between us as physicians and with patients, right? We know medicine, we know diagnoses, we know treatment plans, we know what we're doing. It all comes very easily to us. A lot of the things are very routine, right? But for patients, even if you think it's a minor, minimal complaint, right? It's scary to them. It could be the worst day of their life so far. And when we don't communicate clearly exactly what we're thinking in a way that they can understand, I think it really puts a damper on their experience and on, their thoughts of what exactly is going on in this visit. So I think that's probably the area that communication breaks down the most, right? Our languages don't always match up.
I think that's a really good point. And I think that communication with patients really starts as soon as they enter the emergency department. Often patients have to wait, they have to go to triage, they often have to wait after triage. They might see patients who come in after them, going in before them to be seen, and having that open communication, that messaging to patients about why they're waiting, how long their wait time might be, what the next steps, because a lot of patients, this is their first time coming to the emergency department, and patients don't know what the next steps are. And I think that unknown can cause a lot of suffering. So, one of the things we're really working on is how do we message up front and then also throughout their stay in the ED. And in our emergency department, patients are moving from inside rooms to hallway spaces. They might go back inside a room. They might go to our physician in triage or a wrap area, where they're getting IVs and labs and imaging up front, and then come back to the waiting room and move forward. So there's a lot of movement in our ED, and that's definitely something we're working on in terms of communication with patients. And other areas where I think there could be some communication breakdown is just handoffs between shifts, shift changes, handoffs with consultants, and then also with codes and during resuscitations and some interdisciplinary consults. So there's definitely many areas where we're constantly communicating, and then areas and opportunities for us all to work on.
Absolutely. Yeah. There's dozens of studies out there that show that the sign out process is like the most dangerous part of medicine. So not being able to clearly and concisely communicate what you're thinking to your colleagues, it's just fraught with danger.
Yeah, it's a good point. And talking about patient handoffs, the inpatient teams have SBAR and they have IPASS, and it's so different signing out in emergency medicine. And you might be signing out lots of patients in a very short amount of time. While new patients are coming in, you might have codes and resuscitations that are going on. What are some of the best ways to sign out that you've found in your practice?
It's very site specific, right? Depending on where you're working. I think every different shop has a different culture in terms of how they do their sign out, right? I've worked at places where you do bedside sign out, where you walk around like you're doing medicine rounds and you discuss each patient in front of the patient and you answer questions and you do a brief evaluation, right? That's difficult to do in reality in most ERs, right? Just because of everything you described earlier. Patient movement, right? You write down a patient list, and 3 seconds later, that patient's in a completely different area. So your list is shot. Um, Other places, you sit at the computer and you do your sign out and then you walk around. I think that's much more realistic in terms of a sign out process. I think it's probably a little bit safer and probably a little bit more effective. And then there are other places where it's much looser, where the doctors know each other really well. They're able to very quickly give sign outs and never really walk around, which is probably not the best course of action.
Yeah, and we have one zone in our emergency department, and it's our critical care zone. And I think we have a really amazing way of signing out where we have the rolling computers, everyone signs out together. Like you said, there's different ways of signing out. You could sign out like attending, resident to resident, but in this particular zone, everyone does a group sign out together and then goes from patients to patient and looks at the patient while they sign out and then have the EMR in front of them so they can look at labs and imaging. And I think that works really well, particularly in that area with critically ill patients.
Yeah, I think it's important just to have a standard practice, right? I think when you do the same thing over and over again, you tend to get very good at it and very routine at it, right? I'm a big fan of checklists. You run through each patient, each thing that needs to be pointed out, and each thing you need to follow up on. And if you do that every time, you're going to minimize your errors.
Yeah, it's a really good point. Do you want to talk a little bit about your procedural sedation checklist? And I think it really improved communication during your sedations.
Sure. So one of the things we realized that at our place was that we were missing steps for procedural sedation. And procedural sedation, it's not a free procedure, right? There's real inherent dangers in it. And it's also very closely monitored in most institutions. In fact, in most institutions, it's not really the purview of the emergency department itself to monitor procedural sedation, right? It's the Department of Anesthesia. So there's a lot of eyes on this process. So when you miss steps, it reflects poorly on your department. So what we did was we actually created a procedural sedation checklist, which runs through all of the steps to meet all of the bundle requirements for the procedural sedation to take off that cognitive load from you when you're trying to do these kind of really somewhat risky, tenuous procedures at times, right? So you want your focus to be on the actual procedure, on the actual sedation, making sure that your patient is safe and comes through it, right? But you have to do all the administrative and side work and make sure that, Ramsey scores are done, that end title's on, that your suction is ready, all those things that you have to run through in a checklist in your mind. We've put it down on paper so that you don't miss anything as you go through.
Yeah, and I found that it works really well. And we do sedations often, but it's always good to still have a checklist to go through. And the nursing team goes through the same checklist, the physician team goes through the same checklist. And it's very helpful. And we have something similar for intubations as well. And it really streamlines the communication and makes sure that we're all on the same page.
And that's just it. It's about the communication between the different roles, right? So the checklist is not just for the physician, it's for the resident who's learning how to do the procedural sedation. It's also for the nurse who's doing the procedural sedation with you, right? So when you run through the checklist as a team, you're covering all your roles and double checking each other. When things go well, everybody knows exactly how it's supposed to go. And when things don't go as well, we know what next steps we're taking so that it's not a surprise and everything stays calm and collected. It runs like it should.
Yeah, it's a really good point. So, talking a little bit about consultants in emergency medicine, we communicate a lot with consultants, and sometimes we're calling them at 2 a.m. in the morning and in off hours and weekends. And then sometimes we have very challenging cases. How do we communicate effectively with consultants?
Working in an academic shop, I think that we can actually see how nerve-wracking it is to call consultants on a regular basis from our residents. That goes away with time and the more you do this job. The truth of the matter is that we work in this fishbowl of the emergency department and we need expert consultation sometimes, right? And those expert consultants, while they are wonderful, sometimes they're not going to have the best attitude when they pick up the phone simply because we're giving them work and it's probably the middle of the night. We are fast-paced people, right? We have a tendency to kind of jump right in and talk very quickly and try to get our point across as fast as possible. And I've actually found over time that that is probably the wrong way to go about doing things when you call a consult, right? I think calling a consult, the most important thing you need to have is a clear and concise clinical question for them, right? I don't want somebody with belly pain that I'm just calling surgery and saying, hey, there's a patient with belly pain downstairs. That's never going to go well, right? I want to have a diagnosis. I want to have a patient with acute cholecystitis. And my clinical question is, do you want to take out this gallbladder in the next 12 hours? So when you have that question, it makes their job very easy, especially over the phone. On top of that, I think it's very important to know your patient very well, right? So at any given time, an ER doctor might have, 10 patients, 20 patients. It depends on the shift, right? When you call a consultant, you need to know the information that they're going to ask, right? They're going to ask you what the pertinent labs are, what the pertinent positives, pertinent negatives are. You need to know those off the top of the head. The more time you're taking to dig in the chart to give them the answers to the questions they're asking, the more difficult that consult is going to be for you.
Yeah. And I think you make a lot of great points. And I think over the years, we've met our consultants. When we were residents, we did rotations on their services and really understood their workflows and lived a day in their lives as well. And I think putting yourself in their shoes is really important too. Like you're saying, like understanding what exactly they want, what is that clinical question, and then also building relationships with consultants. And we have an amazing group of consultants, hospitalists located directly in our ED, our medicine admitting hospitalists, and we've learned a lot from them. And it's really great interacting with them. And we see all of our consultants regularly and have really worked on streamlining that communication and building relationships with them.
Sure.
What do you think are some communication best practices when you are talking to patients, caring for patients?
First and foremost, we learn this in medical school, right? You can't talk like a doctor, right? Talking in medical terms is for the consultant, it's not for the patient. You really need to talk to them in a way that they can understand things. I'm a big fan of using metaphors and kind of relaying things in that manner. People seem to understand that a little bit better. Sometimes you have to explain things more than once, right? Especially when you're giving bad news, you have to give them time to digest it and then ask questions and then a lot of times say the exact same thing over again. And then I think in our communication, you always have to be ready for them to ask what the next step is going to be, right? Because that is whether you're giving good news or bad news in the ER, they always want to know what they're going to do next. It's funny when you give bad news, people seem to get a lot more closure than when you tell them that nothing's wrong, right? That there's no medical emergency today, but you need to give them some kind of next step to evaluate, why they presented. Even though it's not an emergency complaint, it's not life or limb threatening, doesn't mean they don't have a medical problem that they need to follow up with a certain kind of doctor. And you can't expect, some random person off the street to understand what doctor or what specialty they're going to follow up with, right? The landscape of American medicine has changed where there's not a primary care doctor for everybody anymore, right? So people are much more specialized. So we have to be able to explain to people who they need to follow up with and in what kind of time frame.
Yeah, I think those are great points. I've also learned to sit down and make eye contact with the patient. Like you said, speak in plain language. And I find that one of the most important things is just listening to their entire chief complaint, understanding why they're here without interrupting them and asking questions in between. And then even at the end, summarizing and saying, oh, this is what I'm hearing, and then giving them an idea of what the next steps are. I think some of that can be very challenging for patients if they don't know what the next steps are. Okay, so next it's labs and imaging, and we anticipate it takes this many minutes to hear back from all of those results. And I'm thinking either going to get admitted or discharged, or I'm not sure yet. I'll tell you again when we come back and revisit. And I know there are so many patients, and get so busy in the ED with procedures and seeing patients and dispositions, making time to go back and talk to the patient and give them updates. And now with technology and the electronic medical records, a lot of patients are receiving results sometimes even before we see patients too, and that can cause a lot of questions or anxiety. So it's always helpful to go back and check in on patients. And then I find that we do a lot of work as emergency medicine physicians, dispositioning patients, talking to consultants, getting them admitted, but making sure that the patient is also aware of that plan for them and they agree with that plan and they want to be admitted, and giving them updates. And even when that admission occurs, they might not know what the next steps are. It's kind of like a black box to many patients. So letting them know that next there's going to be an admitting hospitalist that will come speak with you, and we're waiting for a bed, and you might spend some time in the ED until a bed opens. So letting patients know what the next steps are, I think that really helps with fostering trust and engagement with patients. And then even patients patients that we're discharging, helping them get outpatient follow-up. We've been really working on some integration with our community practices and getting them rapid follow-up as well and giving them access to outpatient follow-up. So that's something that we've been working on at our institution. So, Pete, what are your thoughts about ways that we can communicate better on an interdisciplinary level? Because we are working with an amazing team of people when we're taking care of patients, our nurses or care managers, social work, physical therapy, occupational therapy. What are some good ways to communicate amongst our teams?
I think you hit the nail on the head when we talked about sign out processes earlier, right? In our critical care zone, we round as a team, right? So it's not just physician and physician sign out. You include the residents, you include the lead nurse, you include the nurses of the patients. We include our pharmacists. There's not really PT or T available readily in the department at the sign out process, right? But I think that involving as many people as possible in that process, in that sign out process, keeps everybody on the same page. On top of that, working at a busy place with a lot of turnover in terms of staff. But that being said, I think it's important to get to know the people that you're working with. When you're working in the ER, you work a lot of hours there and you work very closely with the people around you. Like you said, building those relationships, I think is beneficial to patient care. It's much easier for me to just be able to call the cardiologist on the phone and say, hey, I have this guy with chest pain. This is the problem. He needs to come see you next week, than to call a new person I don't have a relationship with. So I think you build sort of a relationship currency with people where what you say carries a lot more weight than if you don't know them at all and they get to know you clinically. So I think that's very important.
Yes, I agree with that. And I also really believe in fostering open communication and encouraging people to communicate. And we do a lot of debriefing, particularly in our critical care area. I think normalizing asking questions amongst all of our team members is really important. And I love when people feel comfortable to ask questions and talk during shifts. And I think that just creates a safer, better, and a better place to work.
Yeah, it's a tough place, right? I think I read a study once where it says the average emergency medicine physician is interrupted every 45 seconds or some crazy number like that, right? So it's very easy to get frustrated with people when they're constantly interrupting you, right? Somebody's handing you an EKG, somebody's asking you if somebody can eat, right? They seem like very minor little things that are interrupting your process, but you have to recognize that everybody has their own process and these things are important. So taking that frustration away and understanding that this is our job, this is the environment we work in, and kind of just keeping a level head and communicating kindly carries a lot of weight.
Yeah, those are really great points. Thank you so much for joining us. It's been an honor to be here and speak about communication in the ED. And thank you, Pete, for all of your great points.
Thanks for having me.